Our next speaker is Duane Attree, who's the CEO of Health Roundtable and the Managing Director of Potentialx. And he'll tell us what these organisations do. But in a nutshell, business seeks to empower knowledge through collaboration and innovation, which is really key to what we're doing here in digital health. So with the Health Roundtable, not-for-profit sector of Duane's life, have the data from over 160 public hospitals that they can look at and analyse, which is shared with them confidentially so that they can look at trends and help those hospitals to improve. With the Potentialx part of his life, it's additional 160 hospitals who are in the private sector. And so Duane's in a unique position with quite a lot of data on what's happening in our healthcare system. And he's a good person to have that data. He's previously in his career worked with DuPont and firms like PwC and KPMG, and he himself has worked in executive management of hospitals as CEO of hospitals in regional Victoria and New South Wales health services. So he gets it from a frontline position from a while ago, and now he's seeing it from the best helicopter view you can with the most data. So on this topic, Duane, of data and insight, and people in the audience have already asked questions earlier today about how can they find these unmet needs or test these unmet needs or get evidence around unmet needs, and this is one of the ways. It's great to have you with us today.
So this is really a case study in Potentialx, and so kind of gives a little bit of an overview of who we are. So apologies for kind of framing too much about us, and we'll move pretty quickly into the sector and what we do. But as Grace kindly introduced, we service over 300 public and private hospitals across Australia, New Zealand, and more recently the Middle East, the UAE. We also do similar work in disability, and we've played with analytics and benchmarks and comparisons across international telehealth, which is quite topical at the minute, primary care and some other related sectors. And really picking up on Kushal and the previous presentation about purpose, our purpose is to answer those three questions across all of our clients. So, the first is, there's just so much data. How do I get, meaningful information such that I know where to focus my improvement? Secondly, how do I know how I'm performing relative to others at an organizational level, at a team level, or at an individual clinician level? And ultimately, this is where we are spending increasingly more and more time, is who's performing best and what can I learn? And our approach is to work through a kind of by industry, for industry model. So we're typically below or working beneath an industry group of some description. Whether that's the Health Roundtable, as Grace said, probably the more well-known brand in the market. We celebrate 25 years this year, and we're meant to be having a big party this week, which we're no longer doing, or the Ability Roundtable or others on the screen. So we take very much an industry lead, but we're kind of sitting in behind, focused on the data and the intelligence. Potentialx is a weird name, so I thought I'd just kind of frame where did this come from. And essentially it came from, I've been the CEO and the managing director now for a couple of years. And as I was trying to develop, our strategy, everyone bar none kept talking about the potential of the business. And so, I kind of took that as something that we needed to play with in terms of the name. And then X was really this, when I probed a bit about, well, what's this potential that you talk about? It was kind of this unknown variable. And so essentially those two things, the parentheses, making a play on our mathematics kind of heritage, came together in this sense of, of purpose for us. So we really focus a lot on, our purpose is to improve lives. And we do that by providing insight, knowledge, data, services that allow our clients to improve lives, and equally internally have a culture that's focused on our staff and improving their well-being. There are three elements to what we provide to all of our clients, whether they be hospitals or disability or telehealth. The first is that an enormous amount of analytical capability and benchmarking. So most of all of this business model is based around Everett Rogers, diffusion of innovation. And so the first step in that is to get some evidence. We then get into a lot of granular detail around improvement communities and groups, and then a significant amount of briefing. So again, coming back to that, there's so much data, particularly in hospitals. Our job is to kind of synthesize that and give advice to typically operational C-suite on where might they focus attention, and more importantly, connect them to their peers such that there's this sort of collective intelligence that builds across the network. And I'll talk a little bit about some of the technology and the services that come from all of this data. Again, picking up some of the themes from the last presenter, we are absolutely a steward of the data. We don't profess to own any data. We simply are custodians of it. And outside of our direct users and clients, we rarely, if ever, identify a hospital or provide any ability to identify a patient or a group. So we quite often get asked for specific patient group data. We rarely provide that outside of our membership-based approach. We're really a secondary use of data company. So we get lots of submissions, which I'll talk a bit about in a minute, but we're constantly changing off the back of that data. We always produce draft reports. We're constantly finding areas of improvement opportunity, and so we ask our hospitals or any of our clients to resend their data. So we're focused a lot on quality data, which I'll talk about. And as a result, we're always looking back and then retrending and recalculating such that we can get specific measures in context that have some value. Where needed, we bring forward ethical oversight. We have committees that look at this and a board that does it. And increasingly, we're reframing our approach around the principles of privacy by design. As we get more and more outward facing, there's clearly interest in partnerships and commercialization opportunities, and kind of very similar to the previous presenter. Having that alignment of purpose, I think, is really important to us, particularly given the first point that it's not our data. The first kind of part to what we focus on is actually getting good data. So this is, again, a little pragmatic tool that we developed about 10 years ago. It does what it says in the title, it barcodes activity. But effectively what it is overcoming the human bias to round up or round down in terms of time. And so it gives us great granular data, particularly in allied health staff. It integrates to EMR platforms, and it can be deployed really simply and easily. Little barcode, connects to the patient administration system, can get all the patient detail and then push back the time and the services that were provided by allied health clinicians. Without it, typically allied health clinicians will have a set of post-it notes or some scrap paper, and they try and write the patient's MRN and what they did, and then at the end of the day they've got to try and allocate their time against the day. Again, harking back to kind of good quality data, this system's also been used by IPA and University of Wollongong to understand time and costs, be they in emergency department or aged care. It's also been used in clinical trials and clinical research to simply point and shoot and get good, accurate data without kind of fear of some of the biases that may come in. It's not perfect, but first point is get good data from the source. That's not always possible, and if you can imagine 300 plus hospitals across 3 countries, 8 to 10 different ways of thinking about when is an admission, those sorts of things, we have a huge amount of capability that's built our own importing system and audit systems and data attribution and value, additional values that get calculated. So this is largely all AI based, lots of machines that kind of continuously look at the data submissions and improve them and audit them. We have over 11,000 submissions in any calendar year, And as you can see at the bottom of the page, 1,834 different audits that we push the data through, such that we've got something that's common and structured and allows us to then move into some benchmarks with that apples to apples comparison. Once we've kind of got the data structured, we really move beyond kind of the findings of the data into the collective intelligence. So we've got this kind of continuous iteration process, robust benchmarking, big data, to put in a buzzword for those playing bingo offline. But effectively what we're trying to do here is we're trying to find difference and understand it using evidence. And not so much poor performance. We're interested in those that are doing something different so that we can learn. And what we then try to do is surface that innovation. So we bring people physically, and over the next few months, through outside circumstances, virtually bring people together to say, well, what is it that you're doing? What's the problem and the solution and the outcome that you have solved for? And what this is doing is getting a peer-to-peer relationship, and increasingly getting a peer that has an opportunity for improvement, the evidence and the decision to act upon it. And from there, we kind of harness that dynamic of the evidence, the reports, but then more importantly, the 2,500 odd people that come to different events, and the innovations that they bring into this sort of collective pool. It's both really rich and granular, but also very human insofar as there's a level of trust of sharing your problems and solutions with people from across your sector. So in that collective intelligence, we're trying to build that supportive network, and more importantly, in terms of business and commercialization, is measure the impact. So what was the effect of that solution at different sites? This framework is one that we use, and we've seen it in every setting, every country, and every professional group. And the quickest I've seen an individual walk through it is about 40 minutes. It was a clinician in New Zealand. But typically at an organisational level, this will take about 12 to 18 months. And so what we find is, why are you measuring that? We don't have a problem, the denial phase. This second phase translates the world over. This data is completely wrong. And so again, kind of is why we focus a lot on getting good structured data. We then end up with the bargaining phase. I need a different metric, or this target I need customized to my context. This is the classic, we're unique. My patients are sicker, my hospital is rural, my hospital is quaternary, etc. Until we get to this phase of, okay, well, maybe we can do better. It's important to note, most of our work is focused on a more action research kind of basis. This is not detailed to the nth degree statistics. We certainly do focus a lot on the robustness, but we're looking at big variance here to identify variation. And so here's an example of that. This is risk adjusted and expected length of stay. And you can see that it's across every pink bar is a hospital. And so what we're really curious about is, what are these hospitals on the two ends of the spectrum doing differently? And starting to unpick that, particularly those on the right-hand side, to say, well, do you have a workforce model? Do you have a technology? Do you have an organizational culture? What is it that's different? And how do we then diffuse and scale that across the rest of the constituents within this example? So that's at a big organizational system-wide level. We then start to identify, well, what might the impact be of an intervention? So this chart tracks the length of stay for people with an avoidable fall from in hospitals. Again, each sort of peak is a hospital. And so you can see clearly the length of stay within injury is quite a lot higher than where there is no complication. And so those 17 days are not only an economic impact, they also increase risk to patients that stay longer with additional complications, infections, and poorer outcomes. So we can start to then say, well, what might the impact be of some intervention on this problem? And then another view of that where each dot is a patient episode group. And so we can see then, clustering around and diagnosing a little bit more at a patient level what might happen or what might be their context. In this case, the numbers of additional diagnoses where they've had a fall. So you can see that, quite visually in terms of the falls with injury having multiple diagnoses versus those with no complications. So increasingly we're moving sort of beyond this notion of secondary use and looking back and benchmarking into, well, how do we now use this in different ways? And so one of those is, we are heavily reliant on administrative and coded data, increasingly looking at clinical data and some of the sources like machines and medtech solutions. But CodeCheck really provides us with our first kind of experiment. It's about 2.5 years old now, where we take all of that data set that we have and start thinking about, well, what might the expected coding be for a particular patient? In the same way that we can predict their mortality or their length of stay or their readmission risk, is starting to think about what might their coding be. And so this effectively starts to address documentation issues, potential coding process issues, and importantly, other opportunities for model of care improvement or clinical governance risks. So for example, we are able to look at medical records that have previously had diabetes within the patient's stay, and if they don't have diabetes in a current stay, then we're flagging, there's a documentation gap here, or potentially you've solved diabetes, at which point we'd be really interested in what you've done differently. But typically it's a documentation or an administrative or coding gap that can be improved. And the other component is then moving that into a freeing up of humans to do the more complex or collective work, so that there's rarely time to do audits or identify those improvements. And so we get the machines to do that work. The two sides to this page here are around sort of the lagging indicators, the looking back indicators, which is where most reporting kind of service providers, be they government or ourselves, are looking at things that have happened in the past. We're kind of moving into this space of prediction and machines that can kind of give their best assessment of where things might be. We're moving into things like leading indicators of performance. And so very focused on how might the human elements of healthcare delivery, staff culture, employment and well-being kind of context, the patient's experience and the patient's context, how might they be leading indicators of performance? And so we are now moving quite rapidly into well-being. And so massive problem, I'm sure anyone that's worked in and around healthcare on the call will agree, the rates of unwell health professionals are really a big issue for us. And so what we're trying to do is think about, well, one, how can we provide some evidence around this problem in a real-time way? And then how might that be used as a leading indicator for operational quality safety type measures? So at a system level, we currently have about 10 health services that have launched Wellbeing in the last few months. And so by the end of this year, we should have some pretty good data to be able to start thinking through the implications of well-being and staff morale. So just finally, and it kind of complements the previous speaker, the digital health solutions are producing incredibly rich data. They're typically well structured, but without that kind of context and a clear purpose, it's kind of just zeros and ones. And so we're really looking and expanding into those things that give greater insight and human factor in terms of the data sets that we collect. We also have a real focus on collect once and use multiple times. And in addition to that, we say submit once in whatever format, and our job is to get that format into something that we can work with and get apples with apples. And very similar to previous speaker around partnerships, and we would say collaboration wins. Our work in the Middle East is a collaboration across 3 different organisations, and it just works really well. Everyone knows their space. We know where we cross over, and collaboration is just more fun once you've got those aligned sort of values in place. And just finally, give you a pretty chart. One of the great privileges of working in this role is you see systems perform. And one of the things that I think everyone should take comfort from, particularly in crises like we're in at the minute, is health systems continuously evolve and improve. Sometimes, in great accordance with, policy and government directives, and sometimes in spite of it. And this kind of chart kind of shows that in a visual sense. So this is risk-adjusted length of stay across a 7 or 8 year period. You can see that the trend is to the left. So typically what that means is health services on the whole are becoming more efficient, more productive. They're able to meet demand and improve quality and safety at the same time. So I think this is a time for optimism and confidence that if we get the right support mechanisms in place, the right, well-being for our people in healthcare, that the system will be able to cope as best possible. That's it from me. Happy to take questions. Thanks, Grace.
Thank you, Duane. And I love that you ended on a positive note in these times when, it does feel like some of these problems are really surfacing due to COVID-19, but also a lot of the attendees, I'm sure, have been hitting their head against the wall in frustration at times in perceived inability of the healthcare system to change. But obviously they are changing, and it's a big beast. It's many moving parts. There's some hope. So thanks for sharing that. I think one of the questions that came through was about that complex chain. So how can you know as an innovator that your solution, while potentially creating efficiency in one sector, isn't going to create a ripple effect and just create a bottleneck somewhere else?
We're spending a fair bit of time as a leadership group on that issue. How do you deal with complexity? So, one of the things that we're really focused on is getting multiple perspectives on that problem. So increasingly using our network to get that perspective seeking, to understand how people think and deal with complexity. And ultimately, a conversation this morning with the team, picking up the phone and asking questions, being curious about what if. We do a lot of scenario planning. So 2 weeks ago, when COVID was kind of starting to look more serious, we sat in a room and went, what if the worst case scenario happens? What would happen to us as a business, to us? We had lots of wargaming kind of scenarios. I'm sure everyone kind of went down similar paths. But in that process, we then broadened that out and sought different perspectives from across the business and our network as to how people viewed the problem. And so finding ways to do that quickly and at scale, particularly for us across 300 plus hospitals, 250,000 employees, is kind of the challenge that we're really looking forward to over the next couple of months, is how can we engage in different ways on some of these complex problems and understand a bit more of the ripple effect as things play out across complex systems. So perspective, I think, is the answer to your question.
No, well, I mean, it's a bit of a philosophical topic. In this time of changing times, will people be going back to, do you think healthcare system will regress in a sense that they'll go back to tried and traditional methods? Or do you think that this is an opportunity and people will be desperately scrambling to innovate and create efficiency? Or do you think that, do you think it'll be a mix? This is just totally philosophical now. What do you feel is going to happen?
So what we see happening in the last week or so is a sense of getting ready. So focusing on things that are the most important now is kind of the mood generally. So, external events, external focus meetings, it is now about locking in behind supporting people at the front line and making sure there's enough people at the front line to handle what we've got in front of us. In addition to that, what we're seeing, and certainly my emails overnight from the US are showing, there's this sense of sharing and collaboration that's occurring. So I had over 150 emails overnight. We have a sister organisation in the States that does similar work to us at a much larger scale. But it was the CEOs and COOs of the vast majority of US hospitals sharing their elective surgery plans, sharing their capacity plans, sharing their workforce models. There's this sense of, we're all in this together. And so whatever we can learn and kind of, take from others and handle the crisis given our context is gratefully received. So those kinds of things are happening across the sector. In Australia, I haven't seen as much of that. I think there's, because of our much more government orientated kind of response, that there's a alignment to directives from the experts within government, but there's still this sense of what's happening down here, what's happening down there, how might we share, public-private collaboration, those kinds of things that we're seeing.
Thanks. Really quick last question, might even be yes, no. Are Potentialx exploring the aged care as a market at all?
Yes.
Getting them on board? Yes. Yeah, cool. Be interesting to see the trends that come out of that.
Yeah, actively, and and not so much aged care on its own, but aged care in the context of its relationship to other parts of the system. So how can we get a joined up view, not so much of the patient, ideally, there's definitely a space for integrated view of the patient, but for us in our space is, what are the opportunities across multiple providers to make the system more efficient, safe, etc., all those kind of balanced dynamics. So aged care for us is definitely in that space.
Thank you, Duane, for calling in from home in this new virtual world, and for answering everyone's questions and for your time today. Thank you very much.
No worries. Great job spinning it up, Grace. Well done.